Thanks
a lot, Dr. Melha, for your kind presentation. Today my presentation is about value of communication with the referral in our nuclear medicine practice. I'll just say a few minutes about the history of nuclear medicine. Since the discovery of radioactivity in 1886, humans had a big dream of how to use this radioactivity in medical practice. But it required 40 years to do the first diagnostic tracer study in humans, which was performed in 1926. The birth date of nuclear medicine is not exactly known, but it is best placed between the discovery of artificial radioactivity in 1934 and the production of radionuclide in 1946. It results from a big collaborative work between scientists of physics, chemistry, engineering, and medicine. But what we exactly know is that the first article in nuclear medicine was published in 7th of December 1946 in the American Journal of Medicine about successful use of radioactive iodine-131 in treatment of metastatic cancer thyroid. This was the earliest use of radioactive iodine. In 1950, the Prof and Dictoronia scanners were developed, and this paved the way for the production of the first ventilation camera in 1958. This goes in parallel with the development of radioimmunoassay, which was extensively used at that time. The Society of Nuclear Medicine was formed in 1954, and it was published in Journal of Nuclear Medicine in 1960 for new research and development of radionuclides and radiopharmaceuticals. In 1960s, the growth of nuclear medicine was phenomenal due to development of the generator system to produce technetium-99M, which is the most commonly used radionuclide till now. By 1970, most organs of the body could be visualized using nuclear medicine procedures, and in 1971, the American Medical Association officially recognized nuclear medicine as a medical specialty, and in 1972, the American Board of Nuclear Medicine was established. The decade of 1980s was the decade of nuclear technology, where pharmaceuticals were designed for use in diagnosis of heart diseases with development of the single photon emission tomography, or SPECT, that led to the three-dimensional reconstruction of the heart. Despite the concept of emission and transmission tomography was introduced in the 1950s, the first PET scanner was installed in 1975 with continuous process for development to improve both resolution and localization. This ended by the fusion images with the installation of the first PET CT in 1998. PET and PCT imaging experienced slower growth in their early years due to the cost of the modality and requirements of an on-site or nearby cyclotron. Yet after around 14 years, PET-CT imaging is now an integral part of oncology for diagnosis, staging, and treatment monitoring, and PET-MRI was installed 1 to 2 years ago with an expectation of comparable success to PET-CT. Nowadays, after around less than 100 years of the first radionuclide study, and after about 50 years of development of the gamma camera by high angle, who you can see in this image, there is a marvelous progress and development in the branch of nuclear medicine. Today, over 10,000 hospitals worldwide use radioisotopes. 18 million nuclear medicine procedures are done in the United States per year, and 10 million in Europe, with a 10% yearly growth in diagnosis using radiopharmaceuticals. The question now is, what is the final product in nuclear medicine? The final product actually is the report. Many of us write a lot of reports every day. This report is to provide the referring physician with a timely answer to the clinical question within the limits of the test, to document the appropriateness, necessity, and performance of the procedure, and for billing requirements. The report should fulfill 6 main items. This includes study identification, clinical information, the procedure, description of findings, impression, and comments. The study identification includes patient name, sex, date of birth, medical record number, requesting physician, type, time of study, and completion dates and time if possible. And the clinical information includes indication of the test, other relevant history, information needed for billing, diagnosis, and if no diagnosis is known, the pertinent symptoms or signs that led to this procedure. Full description of the procedure should be written, including the ready pharmaceutical, the dose given to the patient, route of administration, timing of imaging relative to the ready pharmaceutical administration, drugs, catheters, and devices used, imaging technique, and any complication or patient reactions happen to the patient. Description of findings in the form of the significant positive findings as well as pertinent negative findings, and also we should write the reference range should be used for quantitative indices. The impression, a separate impression should be included, diagnosis if possible, if no differential diagnosis, and judgment about the significance of the pertinent findings may be included also in the impression. And finally, any comments including study limitations, recommendations for any other further procedures, and documentation of direct communication of results, including the name of the physician and time, date of contact. As a matter of fact, working as a nuclear medicine physician in a big hospital, you should spend a lot of time and pay a lot of attention to the process of communication with the referrer. Generally speaking, communication is defined as the interchange of thoughts, opinions, or information by speech or writing. Physicians and other healthcare professionals all agree on the importance of this effective communication. And effective clinical practice involves many instances where critical information must be rapidly and accurately communicated. There are positive outcomes for this, including improved information flow, more effective and rapid intervention, improved safety, improved patient and family satisfaction, decreased length of hospitality, improved trust and confidence, improved quality of healthcare services, and enhanced employee morale. While lack of communication creates situations where medical errors can occur that can cause severe injury or unexpected patient morbidity and mortality. For nuclear medicine, communication is either pre-imaging or post-imaging. Pre-imaging communication from the referral to the nuclear medicine unit for selection of the suitable radionuclide or procedure needed for the patient, or from the nuclear medicine unit to the referrals asking for clarification of any deficient request, to clarify medication that may affect the result of the procedure, and to ask for the conscious status of the patient if coming from ICU or CCU. While post-imaging from the nuclear medicine unit to the referral, telling him about findings likely to have a significant immediate influence on patient care. This should be communicated to the requesting physician or an appropriate representative in a timely manner, and to know the exact clinical status of the patient as well as results of other diagnostic modalities, while from the referral to the nuclear medicine unit speaking about further management and other useful nuclear medicine procedures done, and final communication with the radiologist. We have a single dual head camera in an oncology center attached to a 300-bed hospital. We are in our way to have, inshallah, a new SPECT CT within 1 year. In Jan 2012, we have done 174 patients, nuclear medicine diagnostic studies, 56 of them from the oncology center and 44% from the main hospital. Interprofessional communication was performed in around 40% of our patients. The most common form of communication is telling the referral physician about the result of the technique. This occurs in around 34% of our patients. Now we come to some case presentation. These are some cases with no communication, and then just you write what you find in your report, even if there is an incidental finding. For example, this is a patient with cancer breast presenting for metastatic workup. There is no metastatic lesion, yet there is another thing here. You can see that there is dislocation of both hips. They are not articulating in the acetabular region, but there is pseudo-joint formation in the mid-lateral aspect of both iliac bones. There is no need to communicate, and this just you write this in your report. Another patient with small cell lung cancer for metastatic workup. From the history, you see there is metastatectomy from the brain was done around 3 months before presentation. You can see that there is a well-defined photopenic area surrounded by an active margin, which is a post-operative sequence. Another patient presented for metastatic workup. You can see that there is advanced scoliotic deformity of the dorsal region with degenerative change of the. This is a patient with left renal transition cell carcinoma removed surgically and received adjuvant therapy presenting for bone scan. He has recurrent pelvic pain and intermittent hematuria. No bone metastasis, but there is a well-defined space occupying lesion almost involving the whole left side of the bladder. This should be written in your report, and this confirmed by the CT scan showing a bladder length. This is a patient with bronchogenic carcinoma. It is presenting for bone scan. Bone scan was almost free, but you have evidence of enhanced bilateral pulmonary uptake, which is due to hypercalcemia, which is a paraneoplastic syndrome. It's a patient with nasopharyngeal carcinoma presenting also for metastatic workup prior to starting external beam irradiation. Whole body scan revealed areas of early blood pool imaging. Whole body scan revealed overperfusion in the both cervical region. Clinically, you have cervical lymph nodes larger on the right side, but lead images exclude the presence of any metastatic lesion. Yet we have here skull-based infiltration, which was confirmed by MRI. This must be written also to be involved in the field of radiotherapy. The patient, 16 years old, presented with a soft tissue sarcoma with low back pain, presented for metastatic workup. No bone metastatic lesion yet. You can see evidently there is horseshoe kidney in the blood pool and in the red images. Renal scan was asked for. It excludes the presence of any significant obstruction, urine outflow from either kidney. This is another patient with recurrent pain in the left renal angle. DTPA study revealed left pituitary junction obstruction, but more importantly, here you can see that the renal pelvis is extra-renal. The obstruction is confirmed by IVP. Duplication of the gallbladder occurs once every 5,000 patients per person, and you can see that sometimes during the HIDA scan, you can see that there is two gallbladders, but here they have a common cystic duct. It goes with the Y-shaped type of gallbladder duplication. This patient presenting for bleeding, he is linked for bleeding, but you can see evidently that the spleen has a very low position. This is keeping with the diagnosis of mobile spleen, or what we call wandering spleen. You should write in your report, because it's liable to many complications as torsion, hemorrhage, compression of other organs, or cystic formation. This is a patient with malignant melanoma, operated in the foot, operated in the right foot, operated about 1 year ago, followed by adjuvant chemotherapy. He presented with a painful mass in the right popliteal region. This is the dynamic study in posterior projection. This is the blood pool. There is overperfused area in the right popliteal region. Late static images exclude the presence of any osseous involvement or invasion. No metastatic lesion, the general changes, but more important, you have diffuse worm uptake in the whole right lower limb. This is the sympathetic osteodystrophy. The absence of local invasion was also excluded by CT scan. This is colorectal cancer, present for bone metastasis. The patient has no complaint, but you have a well-defined osteopenic area in the posterior pelvis. This, from the history, can know that he received full dose of radiotherapy 9 months before presentation. This goes with the field of radiotherapy. This is a patient with recurrent non-Hodgkin lymphoma presented with a nasal mass. You can see that there is enhanced very active tracer uptake in the region of the nose and in both cervical region, otherwise no other abnormality. CT scan confirmed the presence of a big mass. Biopsy of this mass confirmed the presence of recurrent non-Hodgkin lymphoma. This is a patient with a post-total parathyroidectomy for the all parathyroid glands removed surgically. A few months later, he has elevated serum calcium, serum parathormone levels. No activity in the site of the normal expected parathyroid glands, also in the intestinal. The parathyroid was implanted in the right forearm. Here you can see that by thalamic scanning there is evidence of increased tracer accumulation in this implanted tissue, which is the cause of recurrent hyperparathyroidism. In all this, no communication was done, because what you can see here, in addition to your finding, can be written in the report. Now we come to the communication. Firstly, from the referral to the nuclear medicine physician. Sometimes you have a phone call from the oncologist. I have a patient with appendicular carcinoma presented for bone scanning. Anything else can be done for him? You told him that yes, we can do technetium arterial scan for this patient. It's a 13 years old boy post removal of the appendix. Histopathology was appendicular carcinoma. The arterial scan was free, just hepatosplenic and renal uptake, which are normal. Aspect data confirmed this. This is the bone scan of the same patient with no distant metastatic osseous lesions. Sometimes you have a phone call from a young doctor telling you that I have a patient with suspected acute cholecystitis. What do you have to do for this patient? Even do not the name of the study you are going to do. You should tell her that we have hide scan done in this the procedures like this, and she sends her patient. Evidently, the study excludes the presence of acute cholecystitis from the early dynamic images with visualization of the gallbladder in the static study. On the other hand, sometimes another one phoned you telling I need to do hide scan for this patient. She has a history of cholecystectomy and she swears that she has done cholecystectomy with a big scar in the right hypochondrium. She has recurrent pain with a sonography from outside telling that she has a gallbladder. There is free passage of the tracer to the intestine, but the gallbladder is not seen even up to 4 hours. But you have here what you can call the rim sign, which is highly impressive the presence of inflammation of the gallbladder affecting the gallbladder bed in the liver, and this was confirmed here by the CT scan showing extended gallbladder with multiple stones inside with thickened wall. This is an acute on top of chronic, acute on top of chronic cholecystitis, which was seen in the MRCP of this patient. All the day around you have requests for nuclear medicine procedures. Some of these requests are complete and very perfect, others with spelling mistake, but the most strange one you can receive some paper like this, just the name, the number, and what is needed written just in Arabic thyroid scan like this. You have to communicate with the doctor directly, just asking what is the exact procedure needed, indication for this procedure, any relevant data, any other helpful investigation, or risk medication to the patient, and finally just you ask him please send a proper request on the computer system to get your appointment. Now we come to the most common form of communication that should be sent directly to the doctor by communication without waiting for the report. The most famous example is the lung scan. Here you can see the lung scan. This normal lung scan shows no perfusion defect. And this one also no perfusion defect. Here you can see that there is maybe enlarged cardiac shadow in this scan. This in contrast to the presence of multiple lateral pulmonary emboli. We have all seen this before. This is a patient present for hide scan also post 24 hours post laparoscopic cholecystectomy with abdominal distension. Ultrasonography showed fluid collection in the abdomen. Here you can say from the early dynamic study there is biliary leak, which was confirmed in static images reaching up to the subdiaphragmatic region, should inform the doctor directly that there is biliary leak. Also another famous example is the presence of GIT bleeding. This colloid scan showing in the posterior projection starting area of abnormal activity appearing here. This in the upper descending colon, mostly in this posterior wall. This was confirmed also by labeled RBCs, and the patient was operated upon and telangiectasia was found in this place. This is another patient, sickler, known to have bilateral avascular necrosis with more severe pain in the right hip region. The doctor just phoning asking about there may be increasing the severity of avascular necrosis. What you can see here is that there is a well-defined area of no tracer uptake keeping with vaso-occlusive crisis, and the avascular necrosis present and moderate on the left side. This is the same patient, dynamic images. It's not very evident here, but it is under-perfused. This is the late static images, a well-defined vaso-occlusive crisis in the trochanteric region of the right femur. Seen also in the posterior projection. This is the X-ray showing avascular necrosis more advanced with starting collapse of the left femoral head. This is another patient with recurrent germ cell tumor with a huge paraortic lymph node causing obstruction to the kidney and displacing the kidney to the lateral side. They started to complain of bilateral lower limb weakness. Bone scan was asked for. Clearly you can see that there is a well-defined big photopenic lesion involving first lumbar vertebra. You cannot wait to write this report, but you should tell them directly to start irradiation to prevent paraplegia. This is a very old technique, was done in the early 90s. I think no one of the new generation have done this before. This is the brain technique was done for brain death. This is a patient has a removal of the left parietal bone. He was comatose. Dynamic image, this was done at that time by DTPA. Dynamic image, so well-defined photopenia in the brain, no evident perfusion, and also in static image, keeping with the diagnosis of brain death. Now, sometimes they are phoning you asking about further management of the patient. This is mostly about well-differentiated thyroid cancer. This is a patient with well-differentiated thyroid cancer, female patient, 70 years old, presenting post-thyroidectomy for radioactive iodine ablation. She received 1 dose, and during follow-up she has a big upper left cervical lymph node, 3 centimeter in diameter. She was referred to the surgeon for consultation. He decided to remove surgical, but she did not present for 2 years. Then she presented in the ER by severe dyspnea. Chest X-ray revealed massive pleural effusion on the left side. A tube was inserted with removal of the fluid and improvement of her symptoms. The fluid actually was hemorrhagic, but no malignant cells in this effusion. CT scan revealed diffuse thickening of the pleura on the left side of this patient, and the decision was to take a pleural biopsy, which is an invasive procedure. Just we phoned the nuclear medicine physician, telling him this decision. Just we told them, please wait for 3 to 4 weeks to stop thyroxine and do firstly whole body scan. If positive, there is no need for this biopsy. This is the whole body scan showing the left upper cervical lymph node, but there is diffuse uptake through the left hemithorax, keeping with the diagnosis of pleural metastatic lesion, which is a rare condition and carries a bad prognostic significance, and patient received single dose, but she expired after 9 months. This is another patient presenting with a pathology report telling the chest carcinoma and performed total thyroidectomy lymph node dissection. Lymph nodes were positive 5/5. But clinically, there are big lymph nodes. The largest one was 4 centimeters in diameter. This is the posterior whole body scan by iodine. This is the anterior. You can see that there is variable size lymph nodes which are positive for metastatic lesions. You will never give reductive iodine for this. You send her back to the surgeon. She had performed bilateral block neck dissection. This is the CT of the same patient showing bilateral cervical lymph node sizable. Here it was. She was operated upon. This is the whole body scan post ablative dose after removal of the whole neck nodes with residual thyroid tissue in the neck. This is another patient with the same clinical condition, but the lymph nodes are slightly smaller. But here, whole body scan lacking any tracer accumulation in the lymph node. Just you have small area of residual thyroid tissue for which she received 30 millicurie iodine on outpatient basis. And this is the CT scan of the same patient, and we have asked for biopsy post-ablation. And the biopsy revealed non-Hodgkin lymphoma. Patient received chemotherapy, 6 courses, and this is a case of double primary lesion. Now sometimes you have a phone call asking for another nuclear medicine diagnostic procedure. This is a patient with pain in the right iliac region. Asked to firstly perform bone scan. There is relative increased uptake in the right iliac bone. More evident is lateral aspect. If you come back to the blood pool images, you can see that there is overperfusion of the iliacus muscle of the right iliac bone, its lateral aspect, and there is an area of overperfusion descending downwards, reaching to the lateral aspect of the proximal right thigh. This is the static images, and gallium scanning was asked for this patient. This is the gallium scan showing also intense uptake in the right iliac region, descending through the iguana region to the outer aspect of the thigh. This is an abscess, mostly inflammatory process with an abscess formation. This was confirmed here by CT scan showing there is an iliacus abscess descending to the proximal part of the floor, of the proximal part of the right leg. This is a patient, a boy sickler with severe pain around both knees. This is the basket for bone scan. Here you can see the dynamic image showing areas and the blood pool images, areas of hypoperfusion in the lower femora and the upper medial aspect of both tibia, like this. The static image is showing also diminished tracer uptake here in the lower half of both femora and the upper medial aspect of the tibia, keeping with the diagnosis of vaso-occlusive crisis. But here the unit asked for gallium scan because of, in the blood pool image you can see that there is little enhanced uptake in the soft tissue around the lower femur. Gallium scanning, this is the 4-hour image showing active uptake in the muscles of the lower femur. This is the 24-hour showing more intense gallium uptake in these areas, in the muscles of soft tissue of the femur. If you compare the bone scan with the gallium scan, here you can see that there is vaso-occlusive crisis in the bone with infarction in the lower femora and upper tibia. This is associated with active infection in the soft tissue and the muscles in the lower femora. This was confirmed by MRI showing also there is infarction in the bone marrow in the femur together with inflammatory process in the muscles with fluid accumulation in this area. So this is one of the cases showing both infarction in the bone associated with soft tissue infection in the muscles in the lower femur. Now we come to the communication with the third party. Actually, in the whole last year, we reviewed a lot about the third partner. We all actually hate this third partner. He is responsible for a lot of destruction and deaths during the Egyptian revolution. But in nuclear medicine, actually, the third partner is well known. Third partner in nuclear medicine is very cooperative and helpful to us. You can see that this is a patient presenting for bone scan, generalized bony pains, female patient. This is a metabolic super scan pattern. Hyperparathyroidism was suggested. Parathermal level was more than 1,000, and the patient was referred for parathyroid scan. Here you can see this well-defined ectopic parathyroid adenoma. This is the early image, this is the date. Like Dr. Medhat have told us, we were so proud of the report, but after 4 days you have a phone call from the endocrinologist. You thought that he's going to thank you for telling the pathology report is adenoma, but he told us that he had done surgical consultation. They asked for a CT scan, but CT scan is negative. For beta localization, there is nothing. I told him, okay, I'm going to speak to the radiologist. We divide the images with the radiology. Here you can see that I told him the lesion is on the left side of the mid-manubrium sternum. On the vision of the image, there is something here. This was over-missed in the radiology, or thought as a rudimentary thymic gland, but the report was corrected, telling that the pathology was positive for parathyroid adenoma. This is a patient, child with abdominal Burkitt's lymphoma. He presents for gallium scanning, just no other extra-abdominal disease, and received 3 courses of chemotherapy. Then after 2.5 months, you have a phone call from the pediatric oncologist telling you that the patient has done CT after 3 courses of chemotherapy and there is a mediastinal mass. Can you repeat the gallium scan? Yes, we can repeat the gallium scan. This is the gallium scan showing complete resolution of the abdominal disease, yet we have something in the mediastinal, but sure, this is a rebound thymic hyperplasia post-chemotherapy. You should go to the radiologist and show the films to them. Here you can see there's a big mass, but it's clear that it takes the topography of the shape of the thymic gland. The report was corrected that this is a rebound thymic hyperplasia. But sometimes the third pattern is very useful to us. You can see this is a patient with cancer breast presenting for bone scan. She has done mastectomy 4 years ago, received only 2 sessions of chemotherapy, and this appeared for 4 years. She presented a very bad condition with the generalized bony aches. She was referred for bone scan. Bone scan actually doesn't reveal a lot of things. Here you can see maybe lytic lesion in the sternum, active tracer obtained in the upper humerus. This doesn't go actually with the clinical status of the patient, but fortunately enough, this patient has done CT chest and abdomen to check for any soft tissue lesion. You should go to the radiology and check with them the whole window of this CT. You can see that all bones of the body are involved by small lytic lesion. This is the dorsal vertebrae, the lumbar, the sacroiliac lesions. Also here the lumbar vertebrae, the sacroiliac, the upper femoral. So there are a lot of lytic lesions that do not appear in our bone scan. Finally, we can conclude that communication with the referrals is very important. You should establish effective collaborative communication with the referrals for the sake of rapid and proper patient diagnosis with subsequent impact on proper management. You should encourage referring physician to write a full request about patient history and giving treating modalities. You should encourage referrals to expand their knowledge about what we are doing in nuclear medicine and all available techniques, especially new ones, and communication helps a lot to build more trust and confidence in nuclear medicine reflected as more patient referrals. Finally, efforts done by our pioneers and professors should be continued by us by doing a lot of procedures. Communication with the referral is one of these procedures. Finally, I'll show you one of the strange nuclear medicine images I have ever seen. Many thanks to you.